Very good evening to all my dear MOS members and the ophthalmic fraternity who have joined for today's sixth journal club meet during my tenure. Today we have the young Turk who is going to do the presentation, Dr. Gautam Pawar, on the randomized phase 3 trial of the port delivery system with ranibizumab for neovascular ERMD. And we have the coordinator, Dr. Devendra Venkatrami, Dr. Rajesh Joshi, and we have with us the panelist, Dr. Raja Narayan and Dr. Prashant Bawankure. And for the statistic analysis, we have Sabyasachi Sen Gupta and Dr. Sethia. So I'm sure it's going to be an interesting presentation. We are already delayed, so without wasting any time, I would like to hand over the session to Dr. Vaishal. Over to you, Vaishal. Vaishal?
Sir, you are muted. Vaishal, sir.
Good evening, everyone, and welcome to the sixth Journal Club meeting. We apologize for the delay because of technical glitches. And without further ado, I would open the Journal Club meeting and ask Dr. Rajesh Joshi to open the meeting.
Yeah, good evening, one and all. On behalf of MOS, I welcome you all to this Journal Club meeting. Today's topic is Archway randomized phase 3 trial of port delivery system with ranibizumab for neovascular age-related macular degeneration. The presenter is Dr. Gautam Pawar, second year DNB student from Lakshmi Eye Institute, Panvel. And to highlight on the topic, we have Dr. Raja Narayan, Director Anand Bajaj Retina Institute to Suven Clinical Research Center, LV Prasad Eye Institute, Hyderabad. Welcome, sir. Dr. Prashant Bawankure, who is a vitreoretina specialist from Sarakshi Nethralaya, Nagpur. Coordinators for today's Journal Club are Dr. Devendra Venkatramani, Dr. Parul Deshpande, Dr. Vaishal Kenia, and statistical experts are Dr. Sabyasachi Sen Gupta and Maninder Sethia. So I welcome you all and request Dr. Gautam to share his presentation on the screen and start the Journal Club. Yeah, Dr. Gautam.
Good evening, everybody. Today I'm going to present on a journal article titled Archway Randomized Phase 3 Trial of the Port Delivery System with ranibizumab for Neovascular Age-Related Macular Degeneration. The author is Nancy Holcomb et al. It was published in Ophthalmology Journal in September 2021. So what is port delivery system? Port delivery system with ranibizumab is an investigational drug delivery system that includes a surgically placed permanent refillable ocular implant that continuously delivers a customized formulation of ranibizumab into the vitreous. The implant reservoir can be refilled repeatedly through a self-sealing septum in the center of the implant flange, allowing for drug replenishment via clinic-based refill exchange procedures. So here on the left, we can see the PDS implant, and in the middle, the PDS has been implanted in the eye, and it is filled with 100 milligram per ml ranibizumab. So on the left photo, you can see the PDS has been implanted 4 millimeters from the limbus in the superotemporal region. The implant flange can be seen. And in the right picture, we can see the PDS implant through a dilated pupil when the patient has been asked to look up. So what is the need for the study? There's a need to lessen the treatment burden in patients with neovascular AMD. Frequent visits for monitoring and treatment are difficult to maintain and pose a significant burden on patients, caregivers, and healthcare providers. Available intravitreal anti-VEGF agents allow for treatment extension to 8 to 12-week intervals and generally require at least 7 injections in the first year to achieve efficacy comparable with that of monthly injections. PDS has been designed to reduce treatment frequency. So the purpose of this clinical trial is to evaluate the safety and efficacy of the port delivery system with ranibizumab for the treatment of neovascular AMD. It is a phase 3 open label randomized clinical trial conducted at 78 US-based study sites. It is a masked non-inferiority and equivalence trial. The inclusion criteria for the study was all patients 50 years and older with a diagnosis of neovascular AMD within 9 months of screening and who had received 3 or more prior anti-VEGF intravitreal injections, either ranibizumab, bevacizumab, or aflibercept, within 6 months of screening, and a demonstrated anatomic and visual response to anti-VEGF treatment. Exclusion criteria included prior treatments for neovascular AMD other than anti-VEGF drugs, subfoveal fibrosis or atrophy, and specific concurrent ocular conditions. So 619 patients were screened for this trial, and of which 201 were excluded since they did not meet the inclusion criteria. The 418 patients were so enrolled, and these were randomized into 2 treatment arms: the PDS ranibizumab 100 mg per ml 24 weekly arm and intravitreal ranibizumab 0.5 mg 4 weekly injection arm. And the randomization ratio was 3:2. So 251 patients were randomized into the PDS study arm, of which 3 patients were excluded. 240 patients entered the primary analysis. Of these, 8 patients discontinued treatment in study eye before the completion of study. And so 240 patients completed study treatment through week 40. In the monthly injection arm, 167 patients entered the primary analysis, of which 5 patients discontinued treatment before the completion of study, and we had 162 patients completing study through week 40. So a block randomization was conducted through an interactive web response system and was stratified by baseline BCVA score of less than 74 ETDRS letters versus more than 74 ETDRS letters. Visual acuity examiners were masked to treatment, study eye assignment, and visit type. They had no access to prior BCVA scores. So for the PDS treatment arm, patients were monitored monthly through trial completion to maintain visual acuity examiner masking. Additional safety visits were performed at day 2 and day 7 after implantation. Supplemental intravitreal ranibizumab injection was given to patients if they had a decrease of 15 ETDRS letters or more from baseline, or if they had an increase of 150 microns or more in the central point thickness on SD-OCT from the lowest CPT measurement in the study. In the monthly injection arm, patients were monitored monthly and received intravitreal ranibizumab 0.5 mg injections at day 1 and then every 4 weeks at monthly visits. So the primary efficacy endpoint was change in BCVA ETDRS letter score from baseline, averaged over weeks 36 and 40. The non-inferiority margin was kept at minus 4.5 letters, and the equivalence margin was plus minus 4.5 letters. The secondary outcomes were proportion of patients with BCVA score of 69 letters or better at the average of weeks 36 and 40. Proportion of patients with loss of fewer than 5 letters, 10 letters, 15 letters, and gain of 0 letters, 5 letters, 15 letters from baseline. Central point thickness changed from baseline at week 36 and 40, and proportion of PDS treated patients who received supplemental intravitreal ranibizumab treatment before first refill exchange procedure. A PDS patient preference questionnaire was used to evaluate the preference of patients for ranibizumab treatment delivered via the PDS or intravitreal injections. It was administered to patients treated with PDS at week 40, and patients were asked to compare the experience of PDS treatment with intravitreal anti-VEGF treatment received before study day 1. Statistical analysis. The estimated sample size at 90% power for the trial was 360, and 418 patients were enrolled in the study. One-sided t-test was done for non-inferiority at alpha of 0.025, and two-sided t-test was done for equivalence at alpha 0.025. The efficacy and safety analysis populations were identical. Baseline was defined as the last available measurement before the first study treatment. A mixed effect model for repeated measures analysis was used for the primary analysis to generate adjusted mean change from baseline BCVA values that accounted for baseline differences between treatment arms. An analysis was conducted using SAS software version 9.4. Results. So this table shows us demographic and baseline data of patients in the PDS arm and the monthly injection arm. The mean age for patients in the PDS arm was 75.2 years, and in the monthly injection arm, 74.8 years. 41.5% were males in the PDS arm and 40.1% in monthly injection arm. Also, 96.8% were of white race in the PDS arm and 96.4% in the monthly injection arm. The baseline BCVA ETDRS mean score for the PDS arm was 74.4 and 75.5 for monthly injection arm. Majority of patients had a baseline BCVA of 20/40 or better, which was 80.6% in the PDS arm and 81.4% in the monthly injection arm. And both patients in both the treatment arms received a mean of 5 anti-VEGF injections prior to the study. So we can see that the demographic and baseline characteristics of the study population are well balanced across treatment arms. In this diagram, we can see the change in BCVA from baseline. The black line indicates patients in the PDS arm, and the gray dotted line indicates patients in the monthly injection arm. And the BCVA has been taken at 4 weekly intervals. And we can see that for patients in the PDS arm, there has been a drop in the BCVA after 1 month of implantation of PDS, but the BCVA soon recovers by week 12. For rest part of the study, the change in BCVA for both the treatment arms is close to the baseline. Also at week 36 and 40, the change in BCVA ETDRS score for PDS is plus 0.2 letters, and for monthly injection arm is plus 0.5 letters. So the two treatment arms are similar with minimal changes in BCVA from baseline through week 40. In this diagram, we can they have shown the difference in change in BCVA for patients between the two treatment arms. So the range is from minus 1.7 to plus 1.1, which is well within the required minus 4.5 to plus 4.5. So the primary efficacy endpoint has been fulfilled by the trial. And so the PDS 24 weekly is both clinically non-inferior and equivalent to monthly intravitreal ranibizumab in terms of BCVA change from baseline at the average of weeks 36 and 40. This diagram shows us that the change in central point thickness from baseline is very close to baseline throughout the period of study. And so the control of retinal thickness with the PDS 24 weekly was comparable with that of monthly ranibizumab through week 40. So of the 248 patients included in the PDS treatment arm, 4 patients received supplemental anti-VEGF injections before the first refill exchange procedure. And of these 4 patients, 3 patients received 1 injection and 1 patient received 2 injections. This table shows us comparison of proportion of patients in PDS arm and monthly injection arm for gain or loss of ETDRS letters. We can see that the proportions are similar in both the groups for different categories of gain or loss of ETDRS letters. For a gain of more than 0 ETDRS letters, 57.8% patients in PDS arm and 58.9% in monthly injection arm, and 1.6% patients had a gain of more than 15 letters in the PDS arm and 1.2% in the monthly injection arm. 85% patients had a loss of less than 5 ETDRS letters in the PDS arm and 88.3% in the monthly injection arm. And 2.4% patients had a loss of more than 15 letters in the PDS arm and 3.1% in the monthly injection arm. So regarding safety assessment, 94.4% patients in the PDS arm had ocular adverse events, but these also include non-significant side effects. And 35.3% had ocular adverse events in the monthly injection arm. And majority of the patients, 91.5%, had adverse event within 1 month of PDS implantation. So more ocular adverse events were seen in the PDS arm, and majority of them were seen in the first month of PDS implantation. Ocular adverse event of special interest, they have included these as conjunctival bleb, vitreous hemorrhage, cataract, conjunctival erosion, conjunctival retraction, endophthalmitis, rhegmatogenous retinal detachment, and hyphema. And we can see that only vitreous hemorrhage and cataract was seen as an adverse event in the monthly injection arm. Rest all adverse events were not seen in the monthly injection arm. So 19% patients had one or more of these adverse events of special interest. in the PDS arm and 6% in the monthly injection arm. Ocular adverse events, ocular serious adverse event. So 14 patients in the PDS arm experienced a total of 20 serious adverse events, and 2 patients in the monthly injection arm experienced 2 ocular serious adverse events. In the PDS arm, 18 patients required 22 additional surgical procedures due to ocular adverse events, including cataract extraction, conjunctival repair, and vitrectomy. So there were a total of 4 patients which required implant removal due to adverse events, of which 1 had endophthalmitis, 1 retinal pigment epithelial detachment, 1 patient had conjunctival retraction, and in 1 patient the implant was damaged. And this damaged implant, the implant became non-functional after an unsuccessful refill exchange procedure was performed. Analysis revealed mechanical damage to the septum subsequent to multiple non-orthogonal refill exchange attempts. The explantation procedure was well tolerated, and BCV after explantation was similar to baseline BCV. The systemic safety profile of PDS arm was comparable with monthly ranibizumab arm. None of the serious adverse events were suspected to be related to study treatment. 2 patients in PDS arm and 1 patient in monthly ranibizumab arm died during the study. Causal relationship with study treatment was not suspected by the investigator in any of these cases. So 11.3% patients in the PDS arm and 9.6% in the monthly injection arm had 1 or more of systemic adverse events, which included pneumonia, urinary tract infection, cerebrovascular accident, pancreatitis, and acute respiratory failure. MARI protocol. Methods. The study hypothesis has been defined. Inclusion and exclusion criteria have been mentioned. Sample size calculation is not mentioned, and statistical power of study is mentioned. Confounding variables have been taken care of, and masking and blinding is done. Assessment is appropriate. The measurement of the outcomes address the study question accurately. Proper statistical test has been applied to analyze the data. Interpretation, meaning of results for those who are included in the study, contributory cause or efficacy. The PDS 24-weekly arm demonstrated non-inferior and equivalent efficacy to monthly ranibizumab. Harms and interactions. Incidence of ocular adverse events were more in the PDS 24-weekly treatment arm. There were no subgroups in the study. Extrapolation, meaning of results for those not included in the investigation. Conclusion of study extends to all individuals of white race. Limitations of the study. Patients included in study were diagnosed with neovascular AMD within 9 months of screening. Further studies are needed to evaluate outcomes in patients with long-term disease who have received years of anti-VEGF therapy. Further studies will need to confirm treatment effectiveness in global populations because Archway was a US-based trial with mostly white patients. Archway trial was not designed to evaluate the number of visits required for monitoring PDS-treated patients. Additional data are needed to assess the long-term performance of the PDS. A conclusion, a continuous ranibizumab delivery via the PDS showed equivalent efficacy to monthly ranibizumab intravitreal injections. 98% patients did not require a supplemental intravitreal ranibizumab injection during the first refill exchange interval. Patient had strong preference for PDS over monthly ranibizumab. PDS has the potential to help reduce frequent visits for treatment and to improve vision outcomes in patients with neovascular AMD in clinical practice. Thank you.
Yeah, thank you, Dr. Gautam, for your presentation. And before we proceed for discussion, I requested Dr. Sabyasachi to highlight on the statistics part and his views on the article.
Thank you, Dr. Rajesh. And so Gautam has presented quite nicely. It's quite complicated when such kind of complex studies are are discussed. So if you are okay with it, can I just share my slide?
Sure.
So I'm going to share my. Yeah. So I think you're able to see my desktop.
Yeah.
Yeah, yeah.
Yeah, yeah.
There's in the presentation also, but put it on the slideshow mode.
This is a PDF, so I'm not going to do any slideshow.
Okay, fine.
Yeah, so few things. Whenever there are such large randomized clinical trials, it's always difficult to sort of pick and choose problems with the methodology. So I thought I'll introduce some of the important terms that all of us should know when we are looking at large clinical trials. First thing is that this is a visual acuity SSR masked trial, right? You cannot mask. Generally, we would mask the SSR for which injection was given, isn't it? But here it's almost impossible because it's subconjunctival. That device is actually seen, so you cannot mask the SSR for which injection was given, but you can actually mask them for visual acuity SSR assessment, and that is the primary outcome, so that is good enough. The other terminologies are non-inferiority and equivalence. So these are two different terminologies, and they are slightly different from each other. Superiority is something that is easy to understand, that is one drug better than the other. Non-inferiority really suggests that is one drug not much worse than the other, and equivalence is it very similar to the other. So non-inferiority really means not much worse, and that is a clinical judgment, and equivalence is not too different. So these are the ones which they have used. Non-inferiority is within 4.5 letters, and equivalence is within plus 4.5 letters. So if you see these, these are different. So there are two different kinds of study designs roll into one, which is sometimes not a good idea, but it can be worked, especially if both the definitions are similar with difference in the sign. Remember that these are all previously treated patients. These are not treatment naive patients. All of them have received previous intravitreal injections within 9 months of screening, right? So they have already received injections. Now here patients are randomized in a ratio of 3:2. That is again not common. These are all coming from the ladder trial. If you see the ladder trial, which is the previous phase 2 study, that is where actually 4 different groups of 4 different dosages of this PDS were tried, and from there all of these sample size and how to randomize and how many in each group is actually coming from. So patients are randomized in 3:2, again not 1:1. So this has some implications in terms of how it is analyzed. And if you look at baseline, their vision is 75 letters, right? So that is as good as it gets, really. So it's already 6.9 or 2032. So it's not going to get any better, really. So here change is only plus to 0.2 letters, right? So because remember that these are not naive patients, but already pre-treated patients. Some statistical concept is so this is adjusted change in BCVA score. This is not actual mean BCVA in one arm versus mean BCVA in the other. These are adjusted mean change in BCVA. So this is done by linear regression and not by a routine mean standard deviation. And so this, that change is standard error is 0. Difference is 0.3 letters, and 95% confidence interval is minus 1.7 to 1.1 letters. Now here, when this 95% confidence interval crosses 0, where on one side it is minus sign and the other it is plus sign, that p can never be significant. So if you see, they have not given any p value anywhere here. It's not at all given, right? But then this clearly says that it is not significant. Then, of course, I think most of us will discuss later on that the percentage of adverse events is way too high for our liking, where 1.6% at endophthalmitis. If you look at that ladder trial, which is the phase 2 trial, that is again 1.7%. So that is very similar. If you look at retinal detachment here, it is close to 1%, which is again, I think, really high for for most of our palates. And in the previous ladder study, that is again 1.6%. Vitreous hemorrhage is 5.2%. In the ladder trial, again, it was 4.5%. So these are not just one-off events. They have been repeated over many studies. So overall, the safety concerns will remain with this device. And the last thing I wanted to sort of highlight is those alpha errors. Those alpha values which are given. I think they should be there in the statistical analysis. No, I think I missed it. Anyway, so those alpha error of 0.025 is generally we would keep it at 0.05. I'll just stop share. So that alpha error basically tells is helpful for sample size calculation. The higher the alpha error, the lower the sample size. So in this case, it is 0.025. If you keep it at 0.01, that is even smaller, then the sample size jumps by at least 300-400. If you make that 0.025 to 0.05, that is increase the alpha error, the sample size again shrinks by at least about 70 to 80 samples. So that alpha error is something which is important to set before sample size calculation, and different trials use different those alpha errors. Thank you.
Thank you, sir. We have with us Dr. Maninder also. So I request him to highlight on the statistics part as well as his views on the article.
I think that's been pretty well covered. My only question is the method for sample size estimation for an equivalence trial is different from the method for a non-inferiority trial. Now, whether they have done it by both the methods so that the trial covers both aspects. And in usually one non-inferiority trial, since the direction is already decided, the alpha is 0.025. Whereas in a equivalence trial, it's bidirectional. So the alpha usually is 0.05. So how have they done it? Like, have they done it as a blanket sample size, or they've just looked at one sample size formula and used it for both? Okay, that was my only concern, because Gautam actually said the sample size was appropriate and described. So Gautam, what do you think? What was done? And you still think it's appropriate?
I'm not sure, sir.
What about Dr. Sen? Is Dr. Sengupta, what do you think? Have they?
Yeah, so yeah, like I said, it's not a great idea to combine both and roll
Yeah.
into one. And that one important and precise reason is that sample size calculations are going to be very variable. So
Yeah.
here they say overall that they haven't really exactly told us. But if you look at the ladder trial, which is the previous study,
Yeah.
so that is what. So I think most of it is coming from there. So that is purely non-inferiority. So I think that's what is at the back
So
end.
they've just used the non-inferiority number for an equivalence number.
Yes, exactly.
Something
so
like that.
Really, yeah, something. Which
So
is not,
Gautam, so then Gautam, that should have been the point in sample size. Like, you are not able to differentiate whether it's a non-inferiority sample size or it's an equivalent sample size. Okay,
Yes.
that's my only point. Otherwise, it was a good presentation, Gautam.
Dr. Maninder, if I may just ask a question, in such a case, if you take the larger sample size, you should be essentially covering for both aspects, isn't it? I mean, both.
Ideally, I would estimate the sample size for an equivalence trial, and I would estimate the sample size for a non-inferiority trial, and the one which gives me the larger number would cover both.
Perfect.
So one quick input, so there are some trials which do this, say the protocol T from drcr.network, which is like the main PAPA trial for diabetic retinopathy treatment. So they are predominantly a non-inferiority, but they also have rolled in a superiority element for patients who have vision of 20/50 or worse. And then they, that is also been mentioned, and there are many different areas in the manuscript where they actually mention that aspect. So you can somehow roll it into one, but most of the time non-inferiority is the one which most people are sticking to.
Yeah, thank you, sir. I want to ask Rajanaran about his views on the article.
Yeah, so very nice presentation, and I am very, very pleased and impressed by the overall quality of the presentation and the discussions which you are having, which is, I hear that it's every month. So that's a very good thing, actually. In fact, I would like to be part of the audience also whenever you have these monthly discussions in the future. At least from the retina perspective, if you have any retina articles being discussed, I would be happy to listen to you all. Overall, I hear a lot of good points on statistical analysis, but where I usually discuss in most of my presentations is the clinical significance or clinical interpretation. And usually I title my presentation as clinical significance beyond p-value. So I will just make a few points. One, some of them were related to the sample size calculation. In the article, they have clearly mentioned about how they have calculated the sample size. That is a one-sided alpha level of 0.025 for non-inferiority, which they have taken. And also they have taken 2 one-sided tests for equivalence. And I agree that whichever sample size is the bigger one, you can cover all possibilities. And typically what happens is you always have a primary outcome measure, and then you have various secondary outcome measures. And in the secondary outcome measures, you tend to have these adverse events and all. But obviously, because adverse events are rare, if you really want to look at adverse events in terms of statistical analysis, you will need thousands and thousands of patients. And the last decade, actually, fortunately, I am very happy nowadays in conferences, we don't hear about Avastin versus Lucentis safety, because in any conference that topic gets used to hijack most of the conference, and everyone will ultimately at the end say, you know, the sample size required is so big. So the point is that if your event rate is very small, that is then event happening, whether it's, let's say, endophthalmitis or a stroke, then the sample size required to calculate a meaningful difference statistically would become very, very large. So that's one thing which you all must remember when you are planning or designing a study. If the baseline event rate of a particular intervention, let us say, for example, I will give you the example of intracameral antibiotics. Let's say intracameral vancomycin or cefuroxime, to be used by cataract surgeons to prevent endophthalmitis. Now, if any of you have looked at these studies, either the European Cataract Surgeons data or Aravind or even LV Prasad Institute, you will see the sample size usually goes into tens of thousands. When the endophthalmitis rate actually for any cataract surgery without an intracameral antibiotic is, let us say, less than 0.1%, and you want to intervene by giving an intracameral antibiotic and say to reduce it to 0.05% or even less, then your sample size is going to be very, very huge. It's easy to have, let's say, a disease which has a 90% mortality rate, and you have a drug which reduces the mortality to 50%, versus a disease which only has a 1% mortality rate, and you want to have a drug which reduces the mortality rate to 0.5%. So you need to be aware that if the baseline rate of event is low already, then your sample size is going to be very high. Why I am bringing this is that, in these studies, whatever we are doing nowadays in terms of visual acuity gain, it becomes very important to not just look at the sample size, to look at p-value. Now, any statistician can give you a sample size for any intervention. You want drug A versus drug B to pass that hurdle, that finish line. A sample size can easily be, you can say a statistician can give you 5,677 patients are required, versus another intervention which is very effective, like the case of mortality rate of, I mentioned 90% coming down to 50%, you can finish off the study with 100 patients also. So more the sample size, the clinical efficacy is generally less. There are other ways of analyzing clinical significance. They are called number needed to treat or number needed to harm. I'm not going into those. That will need elaborate presentations with PowerPoint. But overall, if the number needed to treat is very high, that means to produce one benefit in one patient, you have to treat 100 patients. Then it's probably not very clinically significant. So my overall emphasis of discussion so far is about clinical significance. Statistical significance, statisticians can produce, but the clinical significance, only clinicians can make that interpretation. And for that, you need to have a strong clinical foundation. If your clinical practice, your post-graduation, your fellowship is not strong based on clinical judgment, then statisticians and journal clubs can make you overwhelmed. You may hear nice words from many other people, and you may not understand any of that, and then think that, oh yeah, that looks good and this looks good. This p-value is 0.0001. But I can tell you, lower the p-value doesn't mean that the clinical significance is more. Okay, so let's say if you have intervention A versus intervention B, for example, Lucentis versus Avastin, if you have a p-value of 0.0001, doesn't mean that another study where, let's say, it is Lucentis versus Eylea, the p-value is 0.01, doesn't mean that 0.0001 has a better clinical significance. It's all a game of sample size. Okay, your clinical significance becomes very important. Then you can also have post hoc power analysis. So far, we have heard about power of a study, which is done a priori. If this is the difference between the two arms, and I want 90% power, and then 10% dropout, this is the sample size required. That is what everyone will show in their methodology. But once you have the results, you can do a post hoc power analysis. Now, the a priori analysis is based on an assumption. I think that intraocular pressure will be lowered this much in treatment A or drug A and this much in drug B, and this is my estimated sample size. But you can do a post hoc power analysis because you already have the results now in your study and say, now what was the power in this study? So that means that, you know, if your power is very low, that means results are still questionable, even though your a priori sample size gave you that power. Now, I'll just give a different input about the approach so far about p-values, which is called the frequentist approach. I don't want to go into the overall meaning of p-value. If I start talking about p-value, you will be surprised that p-value is not what we want. But Bayesian approach is the other way to look at statistical analysis of different studies, where you don't have p-values, but you have probabilities pre-test and post-test. It is more easier or easily understood in diagnostic tests. I was mentioning about RT-PCR, you know, sensitivity versus predictive value. I don't know, Devan, if you have had any discussions earlier on diagnostic test, how to interpret a diagnostic test, what is sensitivity versus what is predictive value. But I think overall something like that can be applied to interventional clinical trials also. And what Sabyasachi mentioned was a very important point. Table 1 is baseline data. You make sure that both the groups or all the arms are equally well balanced, clinically judged. Don't look at the p-value for all the variables on the baseline table. While they may be giving, your clinical judgment has to start. If one study arm has a mean age of 72 years and the other has 74 years and the p-value is significant, it doesn't mean anything. Clinically, 72 versus 74 years doesn't mean anything. Sometimes you can have overpowering and you don't know what to make out of it. But in this study, if you see, the baseline visual acuity was 74 letters, and the gain in vision, the graph which was shown of gain in vision, the main outcome measure, was about 0.5 letters. Was that right? Around less than 1 letter. Whereas in most studies, the gain in vision for ARMD is 6 to 10 letters, anywhere between 6.2, 6.8 for Hawk and Harrier. For Anchor, it was almost 10 letters of gain. So why is it that in this study, the gain in vision was not much? That is because what Sabyasachi pointed out, that the baseline vision is already very high. They have already been treated, 74 letters. So don't compare this study's gain in vision versus the gain in vision seen with brolucizumab or aflibercept in their pivotal trials. This study is not meant for that. This study is mainly meant for reducing the burden of injections, but you must know that 74 letters is already very high, as Sunny pointed out, about 6/9. So what happens is, you must have realized the inclusion-exclusion criteria of various studies. 20/40 to 20/320, right? That's a very common one. That is 6/12 to somewhere just less than 6/60. So why do they don't take 6/9 vision included in their study, or 6/7.5 included in their study? That is because what we call as the ceiling effect. If you are already at 6/9 and you are trying to achieve 6/6, by the time the patient gains, you don't know whether the patients could have gained even more, right? So if you have a patient who can gain only 1 line, you have a patient who has 20/25 vision, and all you can gain is 1 line to 20/20. But the drug may be much better than just improving 1 line. So if you take someone at 20/40, you can have 20/30, 20/25, and 20/20. So you have an opportunity to show 3-line gain. 3 lines is 15 letters. But what is this magic of 15 letters? In every study, you will see the outcome measure 15 letter gain versus 15 letter loss of vision. 15 letters or 3 lines. If you remember visual acuity, while we talk at 6/6 in 2020, it is actually angle of resolution. You must have heard of logmar vision, logarithm of minimum angle of resolution. So visual acuity is actually angle which we measure, subtended, which we can resolve or recognize. So 15 letters means doubling of visual angle. So if a patient is improving by 3 lines, the angle of resolution is halving, that is, it's getting half. If the patient is losing 15 letters or 3 lines, the angle of resolution is doubling. So that's why that 15 letters or 3 lines is taken as a standard in visual acuity trials, and based on that is based on the angle of resolution. So I think I have spoken enough now, but I will leave it to the moderators to add anything or ask any more questions. Sorry for the long presentation which I made.
No, sir. Most welcome. I think we will get Dr. Bhavankure's opinion also, and probably if Bhavankur sir, are you there? I don't see your name. Okay, then I'll pose the question to you only, sir, Arun sir. Now, clinically, when we talk about PDS, not only from this study, but also from your reading and from your independent discussions, clinically, what kind of patients do you think that these are really this modality is going to help? Because if we are depending on this questionnaire, for example, here patients are getting 4 weekly injections in a sense, whether they need it or not. And obviously they are going to be happier with an implant versus if they don't have to take those monthly injections. So from a clinical perspective, do you think that this technology has a particular niche or particular scenario where it will be advantageous as opposed to the existing treatment modalities?
That's a great question, Devin. In fact, in a sense, the marketing people for PDS would be really thinking, is this something which, how much effort should they put into in terms of sales and marketing? The biggest difference is PDS is a surgical procedure. Now you have to be a vitreoretinal surgeon, fully trained with all the cutter, 25 gauge, all those things with you to be starting to even think of PDS. Whereas other routine anti-VEGF injections are for medical retina. Comprehensive ophthalmologists are doing medical retina nowadays, ARMD, DME. Now this PDS is for ARMD. Who knows? At some point, someone may try it for DME also. But it is a surgical procedure. Now, surgical procedure cost in the US itself is going to be very high. But in India, again, you have to go to the OR and all those things. So it's not going to be a baseline procedure for everyone, because at baseline, we always start off with the best case scenario kind of impression. The patient always thinks he is going to be having the best outcome. When you say you average letter gain is 6 letters And if we need another 25 letters to gain, forget about 6 letters, that may be for others. I am going to gain 25 letters, and in 3 injections, I will be cured. That's what doctor-patient communication ultimately ends up with. You realize when the patient goes for second, third opinion, you feel as if the patient is telling, my doctor told me in 3 injections, I will be cured. I will be 6 by 6. But anyway, that's the patient mentality. When you offer this procedure, we should be careful that first, those patients should have responded to anti-VEGF injections. Technically, actually, you should have given 3 Lucentis and then only go for this, not 3 aflibercept. Because sometimes, Lucentis doesn't work, but aflibercept works. So then you will be in a big soup. Patient received 3 aflibercept or maybe 10 aflibercept. Now you put him onto PDS with ranibizumab and doesn't respond. What do you do then? So that is something we need to be very careful about. And for some patients, at least in our country, when we are not following treat and extend, sometimes these patients end up receiving maybe 1 or 2 injections in a year, in the 3rd year, 4th year, 5th year. And in those cases, having an implant, and you don't know how often, you just keep refilling. So those are technically difficult questions which we will have. I don't think it's going to be that simple that every patient we start giving PDS. But I would say there are some patients, who we have injected 50 injections, or let's say even 25, 30. Those are probably straightforward cases. I'll say, sir, please come, we'll do this for you. But most of our patients end up just with 5 or 6, and then we will see. So it's going to be a tough call.
Nice. Sunny, your take on the clinical applicability. I mean, you mentioned quite eloquently about the safety aspect is really not, a little discouraging, especially those 4 endophthalmitis. They occurred more than 1 month after the implantation procedure, meaning they are not procedure related. It's like, bleb related endophthalmitis in a sense. So, keeping that safety aspect in mind, and obviously the efficacy you may assume is going to be the same because it's the same drug being used. So there's not much to choose from in either arm. So what's your take on that? And do you think you will really, do you think it's only going to pick up in a sort of clinically relevant way?
Yes, I think that the adverse events are definitely much higher than what we would be willing to settle for. So endophthalmitis and retinal detachment, everything put together, if you see, overall at least 10% patients are getting, I think that's too high. If for brolucizumab, we are talking at about 4% and we are fretting over it. So then, this 10% with serious, like really vision threatening adverse events is really too high. So I would not really be inclined to, straight away and probably, again, wait for the Western experience and then see what's happening and then probably try and adopt that. Other thing that Dr. Raja said, I think is very pertinent is first ensure that patients are already responding to ranibizumab and then think about, prolonging the action. Definitely not for treatment naive patients or one-eyed or something like that. So, somebody who's, typically we would do a treat and extend, and then, people would start relapsing at 8 weeks or 10 weeks, and then we would, go back again and do same more aggressive therapies, and then we would relapse again. So, that is where I would sort of think about a PDS or longer acting molecule like brolucizumab today. So, given how things stand today, I would still look at switching with brolucizumab and not with PDS, simply given that the safety aspect is questionable. That's my take on it.
And I don't know, reading between the lines, it appears that the implant has to be changed, actually replaced every 6 months. Is that, am I right in assuming that? Because, it appears that you have to, does the septum or does the filter get spoiled and you have to replace it?
Yes, so, I think even if you look at the ladder data and also some presentations by Carl Regilio, who has spearheaded the study, you really need to go perpendicular into that implant and then inject. You can't just, go anyhow. So that is a little bit of a issue there also. So if you, forcibly try and put it in, you're not sure what's happening and then there may be damage. So overall, I think, when we are starting out and if we don't have any wet labs or, what, we're not sure where we're putting it, we may end up with, only 6 months and then it may not work. Problem is we will not even know that, that the drug has not gone in or that the implant is damaged or whatever. So That's also a little bit of an issue, I think, in the beginning. We can ask Dr. Prashant for Pavan Kule's review there. Maybe he can give his inputs as well.
I don't see his name, unfortunately. Is he?
Pavan Kule is actually attending a VRSI meeting. He's excused himself. Devendra.
Yeah, another thing, I think cost effectiveness of the implant. That is also important as far as Indian patients are concerned. So once it gets launched in India, and that also need to be studied, because looking at the dropouts, complications, and follow-up, because follow-up would be a problem in Indian population. So if at all it gets launched in India, what is the future of this implant and usefulness of this device in Indian population? Yes, Dr. Rajanaran.
Absolutely, you are right. Upfront, I'm sure the cost of the procedure is going to be much higher than, though the company is going to add this to their, value addition which they are going to give. But insurance companies or other agencies, and even from the patient's perspective, putting upfront capital is going to be a challenge in our country. It's not as if insurance covers and everything is going to be free. So that challenge will always be there, and you have very rightly pointed out that it will be more expensive than routine injections. How much more will be the debate, and then ultimately it will come to that same thing, buy two get one kind of things, offers and all those things will start happening. So that's a major challenge for anybody.
Sir, we also have, patients very often asking after the 6th or 7th or 8th injection that, is there any adverse effect of itne baar aap injection laga rahe ho aankh mein, aankh ko kuch hota to nahi hai? And then they always have this question as, are there going to be these perforations in my eye? I don't think this has been shown histologically or histopathologically. But here we are actually implanting a device which is going to leave some permanent bleb or some permanent, fistula in a sense. So, do you think from a safety point of view, it's much better to inject 25 times versus implant something that is obviously much thicker, bigger, and weakening the eye coats to a larger extent?
No, I don't think so. From that perspective, it has been, I don't see it as a major problem, but I need my threshold for that, is much higher than just 3 injections. I mean, 3 injections was just to show the response, but the acceptability is not about 3 injections probably. Someone who actually wants to take that decision of PDS will be at some point much beyond, let's say, 10 injections or so. I don't know what the answer for that is, but the 3 injections was just to show proof that it works, that's all.
But in that case, sir, why don't we just account for, non-responders? I think there is a stable rate of or reported rate of non-responders to eccentrics. So if it is 3% or 6%, you include that figure in the sample size calculation and go ahead with the study with without having in treatment naive eyes, in a sense, which would give you probably more realistic picture. Or is that the wrong way of looking at it? I don't know.
No, we need to have proof of those patients responding to the drug and then take them on board.
Sure.
And that too, 3 injections in 3 months doesn't qualify for a PDS. I mean, that's one criterion for inclusion, but not the sole criteria for taking the decision for PDS. So yeah, I mean, and when it comes to non-responders, I mean, non-response to ranibizumab probably it's a contraindication to PDS, but you always would have, even in this study, you could have some rescue injection with ranibizumab only. But let's say if you have PDS and with PDS, you still start getting fluid and the fluid starts increasing. Can you inject, let's say, some other anti-VEGF, brolucizumab or aflibercept in the eye, not through the PDS, but as a regular intravitreal injection? Can that be done? It should be possible, but you will still need studies. And I'm sure PDS and the overall, anti-VEGF behavior pattern, I think that there will be some patients who after a year or so may not respond to this PDF ranibizumab. And then what do you do? Can you inject aflibercept at that time? Can you inject brolucizumab at that time? What do you do? And then at what point do you remove that implant because you think that ranibizumab is no longer working? So those are the big questions which will come up. But if something works, I'm looking at a more generic implant which can work for any of these drugs. So if ranibizumab is not working, you inject into the PDS some other molecule, but this is proprietary, what all, right now they say it works only with ranibizumab, but if there is some other implant, that would be very good, which is agnostic to the specific monoclonal antibody or anti-VEGF.
So there's a question, Sunny. Do you know of any studies ongoing of this implant in any other retinal conditions apart from AMD, whether it's DME or BRB?
Yeah, that ladder and Archie are the overarching sort of studies for this. So I'm not really aware of anything other than these. I would actually like to see a comparison arm where you have say something like treat and extend with ranibizumab. I think that would be probably making more sense now because most of us would not be doing a monthly injections after the first 3 loading doses. We would mostly go to a treat and extend. So I think any comparison arms should have been a treat and extend arm, at least for the phase 3 trials. But then unfortunately we don't have that, and I don't know of any other studies which are happening for any other indication.
Right on the money, Sabyasachi. The other thing is the question on pachychoroid disease, where I think the presenter was Dr. Gautam Pawar, right? Yes. The last slide which he mentioned, extrapolation, Caucasian population and whites. So their ARMD versus our PCV, it's always a debate, and you should be very, very cautious about extrapolating blindly without any data, and that's why our DCGI mandates that study patients should have been enrolled from India also. Separate subset analysis should be possible, and other countries like Japan and China require a separate study itself, and ours, if we have not participated like Archway and Ladder, they will ask for a phase 4 trial to validate. So it won't be just directly into the market.
Just a closing question from my side. Why is it that most of these anti-VEGF trials initially start with neovascular AMD and not occlusions or diabetic macular edema? Is it some difference in the? Is it easier to do it in neovascular AMD, these trials, or is it some other reason that I can't figure?
Devan, you need to be a businessman for this. So as a clinician in India, we are asking this question because what's more common in India? DME. What's more common in the West, Caucasians? AMD. You don't have DME that much over there. So the money is more in AMD. Let's say not the money, the requirement of the population is more in AMD. This is a simple, straightforward calculation.
Rajesh sir, anything from your side?
Even can I just quickly give my thought on that?
Yes.
Yeah.
Sure, sir.
Yeah, so basically, I think that overall these drugs have evolved in that pattern where Lucentis was approved for neovascular AMD and then other indications. And then aflibercept followed suit where, the first thing that they looked at is neovascular AMD. I think that is also more of a, of course, the requirement is high, but overall, that is sort of the pattern which most drugs are evolving. Same goes with now, faricimab and all of these others. So that's sort of a protocol which has also formed. So maybe, we should think about breaking it with our Indian patients.
There's a protocol which has been found, but if there is a new drug found by a new company in India or any company in India, and if they want to start off an Indian trial first, I'm sure they would go for DME rather than ARMD.
So we are running short of time now. So can we, it was a great discussion on the topic. So definitely PDS is not the way around. I think as Dr. Rajanaran rightly said, clinically intravitreal injections will still stay and indications of PDS will be very select. So I ask Dr. Rajesh Joshi to give a vote of thanks.
Yeah, thank you.
For that, Rajesh, we'll have a gallery view photo and the encode video quickly.
Yeah.
Anmol, let's have the gallery view photo of everybody. Everybody keep your video on. Are you through with it, Anmol? Yeah. Over to you, Rajesh. A fantastic session, Mr. Rajanarayan sir. Very good inputs by Sabya Sachi and Dr. Sethi also, and well coordinated by you and Dr. Devendra, as usual. Very well presented by Ganesh Pawar.
Yeah, the essence of today's discussion was the more trials are needed to establish safety and efficacy of this new delivery system. Thank you, Dr. Raja and Dr. Prashant, for sparing your valuable time and highlighting on various aspects of AMT and its treatment by new delivery system. I thank Dr. Gautam for presenting today's topic. You really presented well, Gautam. Many thanks to coordinators for today's journal club, Dr. Devendra, Dr. Parul, Dr. Vaishal, statistical experts, Dr. Sabyasachi, Dr. Maninder for valuable inputs. I'm sorry for the typo error in the flyer for Dr. Sabyasachi. Please excuse me, this will not happen in future flyers. I'm also thankful to all those who joined on virtual platform. Thanks to Entor for the technical support. Thank you and good night.